Welcome, everybody, and special welcome to those I've already had the honor of meeting. So tonight's wonderful program is entitled Dementia Has Entered Our Lives, Now What? And Judy, you're going to admit people in? They're still coming. And the conversation that we'll have tonight with Suzanne Raulette will provide an overview of the most fundamental pieces of information for you, for caregivers, primarily focusing on communication, safety, and more challenging symptoms of dementia, with lots of time, as Judy said, left for questions and answers. We'll also offer resources for next steps in the journey. And by the way, during the course of Susan's talk, as any questions come up, just enter them into chat. And so now I have the pleasure of introducing our speaker, Suzanne Raulette, who is the program director for the MGH Dementia Care Collaborative. Susan serves as social work clinician for the Caregiver Support Program in Geriatric Psychiatry and Geriatric Medicine Consultation Service. She led the Alzheimer's Association establishment of their care consultation services for families beginning in 2005 and has written multiple curricula on dementia and caregiving. Susan has worked for 14 years specifically focused on helping those living with dementia and their caregivers to have the best possible life despite the diagnosis. She received her master's degree in social work from Boston College. And I know I share with my colleagues our delight that she is our director. So Susan, all yours. Thank you.
Thank you, Barbara, for that lovely introduction. Welcome, everyone. I so wish we were together. I wish we were in a warm auditorium right now, all drinking our coffee and eating a little something together and being able to share. So as well as we can use Zoom, please do to put your questions in, because I want to have a really robust discussion after I go through a few slides here to just cover some of the basic information that I wanted to talk about. So dementia has entered our lives. Now what? This is a question that I get so much from people who are new to the diagnosis, as well as from people who've been experiencing it for a while. They're always sort of looking back and saying to me, I wish we had had more guidance. I wish we had known what to do. How do you navigate this situation? We weren't given the information that we needed, is what I hear a lot. The system is so complicated, we didn't know where to start. And I wish that someone had told us where to go and what to do to start learning. And there's so many different ways I could have approached this. There's probably 15 different ways in my mind I could have approached it. So this is what we have tonight, but I'm open to all questions when we get to the questions and answers, okay? So the most important take-home message of today is that we want to recognize that responding proactively, we can maximize independence and preserve dignity for the person with dementia. So that's kind of a really big statement. If we learn some strategies and techniques, we can really be proactive in maximizing independence and preserving dignity. I'll talk about how that works. So this is a suggested path of sorts that we hope will help you to improve quality of life despite dementia. We want to decrease anxiety, decrease depression, help you sleep better. Wouldn't that be wonderful? Help you to manage the number of things that you're dealing with better, and really to help avoid burnout if we can. So really, in my view, I can't say this strongly enough, it's about learning. And, I think that it's a disease that a lot of people, we're all frightened of it. I'm frightened of it for myself and for my families. And when it comes into your life, it's so serious. We want to get on top of it immediately. We want to get on top of it as early as possible so that we have a better chance of coping with it in a positive way, despite the heaviness of it. And I'll talk more about that. So understanding the cause of the impairment or a diagnosis, if possible. I know everyone does not get a diagnosis of Alzheimer's disease or a related disorder, but if there's any way to understand if this is a chronic disease, is this going to be a degenerative disease, brain degenerative disease, or is this something that we may be able to turn around? Is there possibly a cure for this? So at the very least, we want to know what is causing this to happen. Basic knowledge of what to expect in the future. And I think that should be provided by the doctor who opens up about the diagnosis, who's able to give a diagnosis. Some basic knowledge of what to expect in the future. Resources for emotional support, additional informal help. So in the beginning, I don't think you have to run out and hire somebody to do things for you, but we begin to look around us in our friends and family and our community. And there's a lot of people that if they know what to do and how to help, they might be very willing and eager and compassionate in their willingness to help. So once we sort of understand what's going on, what the diagnosis is, what to kind of expect in the future, we start looking around, who is our team going to be? Who is going to be my team? Even if that's somebody I can call up and talk about the football game, or call up and talk about whatever's going on that you want to talk about, and not always about Alzheimer's disease. Who is our team going to be? Who is going to provide comfort, and who is going to rally around us when we need it? We want to really have sound fundamental skills to approach some of the changes that happen to a person's personality, the way they perceive the world, the way they navigate the world. It all changes. And so we want some skills to be able to help them through this and to help you help them through this, right? So those fundamental skills also help us to address safety concerns with positivity and compassionately and with as much patience as is all possible. So we're going to talk about all this a little bit more. Then at later date, you might want to start looking into what are more formal resources. If there's a progression of the disease, at some point, more help is needed. And then finally, I have here resources and plans to cultivate and not lose sight of the caregiver, the health and the resiliency of the caregiver and care partners, okay? So that's a path of sorts in my mind about the things that you really need to do. So we want to start beginning to reframe life with dementia. There's a lot of life to be lived day to day. There's a lot of joy to be had. Communication is possible. We have to change how we communicate, but all the way through end disease, I have had the experience that there is a way to communicate. It's different, but we can learn how to communicate. Focus on remaining abilities and skills rather than on what's lost. We can really get bogged down with, of course, grieving is so important, and it's going to be a part of what we're going to talk about today. But as much as we can, we also want to balance that with focusing on remaining abilities and skills. We want to welcome big and small successes. So if somebody hasn't showered in a couple of weeks or longer, and we finally get in the shower, that's a big celebration. Or if somebody didn't eat yesterday and we ate today, that's a big celebration. You kind of got to get, become aware of the little things. It's really the little things that can be a success that you need to celebrate and welcome. So moments of joy, contentedness, and comfort are the goal. So I took a slide from the Alzheimer's Association to kind of, I didn't want to do this talk without touching on some of the basics of what dementia is and what it means in our life. So as I mentioned, dementia is a collective symptoms related to cognitive decline. It's not a diagnosis. Saying that someone has dementia is a description of their signs and symptoms. It's not a diagnosis. A diagnosis is the disease that's causing the symptoms of dementia. So Alzheimer's disease is a cause for the signs and symptoms of dementia. Lewy body dementia, frontal temporal lobe dementia, vascular disease, Parkinson's disease, sometimes, not always, but sometimes can lead to some signs and symptoms of dementia. It can include cognitive, but also behavioral and psychological symptoms. It's all due to biological changes in the brain. You know, a slide I did not include tonight, but I like to talk about is, because I get so many questions about it, sometimes the behaviors that we see, is the person just stubborn? Are they doing this despite me? Are they acting this way because they're mad at me or something? And it's not. The changes are all due to biological changes in the brain. Alzheimer's is the most common cause. I think it's about 80% of the cases. I'm forgetting my percentages, so don't quote me on that, but it's a large percentage of the people with dementia have Alzheimer's disease. Mixed dementia is very prevalent. So you will often see Alzheimer's disease and vascular dementia at the same time. There's a lot of people who have Lewy body disease and also have Alzheimer's disease. Some causes of cognitive decline are reversible and truly not dementia. So there is every reason in the world to see a doctor immediately if you have concerns about your memory or someone else's memory. Okay. So the 10 warning signs, and I'm going to say that most of you, if you already know Barbara Moskowitz, this is a review for you. So just bear with me, and a review never hurts. Repetition is always a good thing when you're learning. So the 10 warning signs include memory loss that disrupts daily life. So that helps me. That's a big one for me because I, for example, lose my keys a couple of times on a daily basis. I do not know why I cannot keep up with them, but I'm able to retrace my steps, and I kind of know where they are usually. I can always find them. Knock on wood. Knock on wood. It's not disrupting my daily life. We're talking about memory problems that disrupt daily life. Challenges in planning and solving problems. So it's not just memory, it's also planning and problem solving. Difficulty completing familiar tasks, like the coffee maker or the remote control or something that used to be kind of a simple task is no longer simple. Confusion with time or place, trouble with visual and spatial perception. I think this happens earlier in the process of Alzheimer's disease that people realize. So there become problems with depth perception is a big one. Peripheral vision is decreased. There's a narrowing of the visual field. So those are things that you don't think about when you think about dementia, but it happens very early on. New problems with words in speaking or writing, misplacing things and losing the ability to retrace your steps. Decreased or poor judgment, where there used to be better judgment and good decision-making. Withdrawal from work or social activities, changes in mood and personality. We had a doctor, I don't know if it was just last month or I think it was the month before, who mentioned sometimes someone who's been kind of irritable, maybe, let's say, through their life, suddenly the personality change can be that they become more quiet and more calm and more passive. So it's not always that the person will become more agitated or more anxious, though that's very common. It's not all the time, which is a question I get a lot. So bear with this picture of the brain. We don't have to memorize it, but it's just to make a point that memory, language, reasoning, judgment, planning, behavioral control, physical function, speech, vision, hearing, it's all affected by dementia. Every part of the brain is eventually affected. not in the same order, not at the same pace. So the time frame is different for different people, and the way it progresses is different for different people. But for people, if you you can learn a lot about sort of red flags, how to predict where you are, how to kind of gauge what is needed, what stage you're at, those kinds of things we can teach people. So I'm going to take a step back. I don't know if any of you have taken the Dementia Friends class, but I saw this slide and I loved it. So I took it. And I think if any of my dementia friends are on here, I hope it's okay that I took the slide. I'm sure it is. So on the left is a healthy brain. It's got, and the books are like memories. So the memories are all there. It's a full bookshelf. I think of our librarian in our brain just is getting older with us. So sometimes our librarian is a little slower, maybe, and takes longer to find things, but our librarian can find things. Eventually he or she starts taking breaks and then some vacations, and maybe then just retires completely. But that would be very toward what's on the right-hand side, which is up at the top is where the most recent memories would be. And so the memories are sort of lost in a backwards way. So we fill up the shelves from the bottom to the top. And as we lose memories, the most recent memories are what we lose first. Then more recent, but more in the distant past kinds of memories. Things in the very, very distant past are usually present for a very, very long time, which is so confusing. It's something I hear a lot is, my sister can't remember what she had for breakfast, but she can tell me everything in the world about our 10th birthday party, right? All those things from a very long time ago are now more present in the front of their mind because they're losing the things that are at the top here. So this picture of the brain is one that I hate to show it, and I debate it every time, but I always end up showing it because it is just so hard, I think, to really fully accept what's happening in the brain. So this is a picture of a brain on the right-hand side. The advanced Alzheimer's brain is if someone were to live all the way through the disease, all the way through the end of the disease. But when I'm standing with someone who has dementia and they may be frustrated, or I can't get them to turn around, or I can't accomplish the task that we're trying to accomplish together, this picture comes to mind. And I take a deep breath, it makes my shoulders relax, and my compassion just kind of overcomes me. And I remember that this is a brain disease and what's happening in the brain. It helps me to be a better caregiver. So why do we always talk about the brain so much? Partly because so many things about dementia are illogical and difficult to explain. But that doesn't stop us from trying to apply logic and apply reasoning to things that happen. I catch myself all the time when I'm talking to someone on the phone. I'll be sitting there trying to reason out why somebody is doing a particular behavior. And I think, wait a second, it's not logical. I shouldn't be trying to figure this out. It has to do with the disease. And so we have to approach the disease differently. This isn't a neurology lesson, nor do we need to memorize the anatomy of the brain. We just hope it helps to briefly review areas of the brain that impact safety and behavior to inform our approach and our response. We want you to have confidence when you are faced with difficult decisions and choices. The more you know, the better hopefully it will be when you have to make some difficult decisions and choices. So this is my path. Habilitation therapy is sort of my guide to caring for someone with dementia. It was it's written by Paul Rea, and then some of his colleagues. And I had the privilege of working with Paul for a decade at the Alzheimer's Association. He was there for 35 plus years and really was there at the beginning of figuring out what we know now works and helps to care for someone. So habilitation therapy is really based on positive emotions. And we work with those positive emotions in a number of different ways. Effective communication, the environment, having a dementia-friendly environment, having structure and routine, activity and social engagement, and mental stimulation. Now, doesn't that sound great if we could just do all of those things, just lickety-split? That'd just be so nice. This is what we strive for, right? These are things that we know are helpful. So whenever we can get one of these things in, it's something to celebrate again, but it's what we strive for. So the foundation of habilitation is communication. And that includes talking and listening, relating in nonverbal ways. So our body language, our facial expression, our tone of voice, and joining the person where they are. So joining their reality. And I'll talk more about what that means. And please ask questions if you have examples of that. If you have questions about it, I'm happy to talk more about that. To decrease anxiety, improve interactions and communication, we do want to offer comfort and reassurance. Again, we want to join the person's reality. We want to respond to the emotions behind the words more than the story. So one of my mottos is feelings, not facts. I almost said it backwards. We really want to listen to the feelings behind whatever we're talking about. The part of the brain that that controls your emotions is the last part of the brain to be affected by Alzheimer's disease and related dementias. It usually stays intact all the way through the end of disease. So there's the emotional piece of the person is really driving in the driver's seat. So we really want to focus on reassurance and comfort rather than getting mixed up in the content of a story that may not make sense or a question that doesn't really make sense. And I can talk more about that. That's sort of an overview. We want to avoid distractions in the environment. So I've walked into houses so many times and there's a TV blaring on the first floor, and up in the kitchen, the radio is going, and there's kids running around. And I think, especially around the holidays, the noise from all the different things that are happening. So we want to avoid distractions in the environment. We also want to avoid trying to convince or talk someone into something that they don't understand or they're having trouble accepting or understanding what you're talking about. So trying to convince is really trying to be logical. And sometimes that logic just goes out the window. So we don't want to argue. We're taking a positive approach. So arguing is not part of habilitation, nor do we want to correct people. So if someone misstates something, misperceives something, or makes a mistake in what they're saying, you don't need to correct. I had a conversation just today with the most lovely woman who has been with her husband since they knew each other in grade school and have been married for 56 years. And she has stated that she gets really frustrated with her husband when he's making mistakes, like he couldn't do a simple task like pack his suitcase or something. And she will get so frustrated with him that she will tell him how frustrated she is. She's been known to argue with him at times. To not do that to her feels like it's accepting that something's really wrong. So today she called me and she said, we had a big kerfuffle. Something happened with the suitcase. It fell apart. I don't know what happened, but he was very frustrated trying to fix it. And she was so frustrated with him because he was making things worse, I think. And she said, I just stopped myself, didn't even think about it, and just reassured him that we would figure it out. Let's go try to find 2 other suitcases to replace this one. We don't have to worry about it. We don't need to get the big saw out to try. That's where things were headed, was getting the saw out. We don't want to get the saw out. We're gonna figure this out together. She didn't yell, she didn't argue. He was fine. And she just finally experienced the difference that can make, rather than an argument kind of blowing up between them, which has happened several times a day. She stopped herself and she had success. And I think she's going to be able to continue to do that. So use of body language, we want to avoid sudden movements. We want to be open and relaxed with our physical stance. Calm and confident to provide reassurance. Use gestures such as pointing and modeling, less words. Sometimes less is more. So rather than a lot of talking, pointing, modeling, gesturing can be helpful. Using visual cues. And unspoken communication, like show me what you're trying to say. Can you show me, rather than trying to say it? And some people have different ways of trying to strive for this particular fundamental skill of being relaxed and calm and reassuring, because it's one of the hardest things to do. But sometimes I think people have taught me that from the car to the front door, there's about however many steps you have. If there's 10 steps or 20 steps or 30 steps, that is a time to kind of shift gears, to physically shake off whatever the day had brought you to that point, so that when you walk through the door, you can kind of hang your stuff from the day hang it on the wall and walk in sort of in a positive and confident and calm and open and relaxed. When I visit people at facilities, I often spend an elevator ride. Elevators are great for this. As soon as I push that button, I put my shoulders down, shake my arms, shake off the day. So as soon as that elevator door opens, I can be present. So let's talk about some more challenging symptoms really quickly. So we call these symptoms behavioral and psychiatric symptoms, BPSD. So recognize that all behaviors are a form of communication. We want to learn and we want to adapt skills that have been proven to prevent, reduce, or even eliminate these more challenging behaviors. So if you guys have examples of some of these more challenging behaviors, I'd love to hear them in the chat when we have a time to talk. Some examples are agitation, becoming frustrated and angry, maybe tearing something up or throwing something, some of those more challenging situations that come up with frustration. It can also be things like my mentor, Paul Rhea, one of his favorite stories was the gentleman who would always use the green trash can in the bathroom as his toilet. And Paul walked into the room and there was a white sink and a white bathtub and a white floor and a white toilet. And then there was a green wastebasket. So he thought, what do we do something to bring our eye and our attention toward where he should be using and take out the green trash can. So that's just another example of thinking about problem solving around some challenging behaviors. So we want to respond rather than react, just like the woman I described who I spoke to today, responding rather than reacting in an angry way. We want to tend to the emotion rather than the story. I think one great example of this that we hear so often is waking up in the middle of the night and saying, I want to go home. I want to go home. I want to go home. And your automatic human response is to say, you are home. Of course you're home. We're home. I'm here. We're together. We're home. It's not working. yeah, no, this is not my home. What I hear in that is really not that they want to go to an old house where they grew up, or not that they want to go to someone else's house. It's really, nothing is familiar to me. I want to be in a place where I feel safe, where things are familiar, and where I know what's going on around me. So I hear that story behind those words. And so I want to tend to those emotions, the emotions of being scared, being unsure, being wanting to feel safe and not feeling safe. So that's what we mean by responding to the emotion rather than the story. So always consider context. What's happening in the environment? Are there a lot of distractions going on? How is the person feeling physically, emotionally? Who's around? How are you feeling? How did you respond? The physical thing that I think we all want to be aware of is how common it is for people to have a urinary tract infection. And if you haven't learned this, it's the first thing you should think about if someone has behavior changes overnight. If behavior changes or personality changes happen really quickly overnight, the first thing you want to think of is there some infection or some physical problem that is contributing to this? We want to eliminate disagreements or details that may cause anxiety and fear and defensiveness. Again, less is more. So when you're saying, for instance, if there's a doctor's appointment we need to go to today, maybe leaving out the details of what the appointment is for, just providing the information that is most important and that will get you there with the least disagreement and the least anxiety and the least defensiveness. Which means taking out the piece of information that makes this task or this activity okay for the person. So I'll talk a little bit more about that, but that focusing on what may make it okay for the first person really goes back to feelings, not facts. So step one with these more difficult symptoms is to be prepared, responding with therapeutic methods in mind. So one thing that I learned along the way is that our human response is natural. Of course, our human response is to be frustrated, to lose patience, to be corrective, right? But to be therapeutic, it requires us to take lots of deep breaths, remembering that it is your approach that will often make the difference, not arguing, correcting, or trying to convince. Approach with a positive physical presence, relaxed, soft tone of voice and facial expression. Respond to the underlying emotion more than the story. As I've said over and over again, I can't say it enough. Staying calm and confident, and often the person will mirror your demeanor. So that's something interesting to try. So step two is really being in the moment. And this is another mantra I have, the mantra of reassure, redirect, and distract. Really reassuring the emotions as we talked about. We don't want you to make anything up. We don't want you to lie, because I can't lie. If I try to say something that's not true, I dig myself a hole so deep and I just make everything worse, right? But we have this concept of a therapeutic fiblet, which I talked about a little bit already, which is not that you're making something up, but that you're leaving the details out and you're just finding the piece of information that's going to make it okay. I have one example of that I would say really quickly. I have a family who's trying to help their father move to Colorado to be with them. And so they thought they would start with, Dad, come and visit us for Christmas. Come and visit us in Colorado. We have this great place set up for you to stay. There's a baby coming in January. Get him to stay for January for the baby and see how it's going. See if it's working out. See if they can make it work. Those are trying to help him understand a long-term plan, and that they're thinking about him moving to Colorado to be close to the kids is way too much information for him to understand. And actually, somebody told him that the kids were thinking about him not returning to Massachusetts, and he became convinced they were going to kidnap him. So they were doing such a lovely job with really trying to make it okay for him. And as soon as he heard this long-term plan, he got really scared and fearful because he couldn't imagine it. It was too much information for him. So that's an example of a therapeutic fiblet. And then distracting. So if you're in the middle of a situation like I want to go home, you want to reassure that the person is safe. We want to redirect while we're waiting. Let's go get a cup of tea. Let's go have a snack. In my life, as a caregiver, we have lots of snacks. For some reason, redirecting someone to a snack or to something that might be visually impactful to look at, to a different activity. Redirection is the next step, and then distracting, and I'm thinking therapeutically. So the idea is if you sit down with a cup of tea, that the warmth of the cup, the smell of the tea will be distracting. And you can start to change the conversation and move the conversation off of, I want to go home, I want to go home. Now, this may take 2 minutes, it may take 2 hours, I don't know. But the idea is the concept of redirection and distraction and reassurance. And then the third step is just to do whatever works. So it may be a therapeutic fiblet, it may be a hand on the shoulder or an arm around the back, right? Sometimes a hug, if the person can accept it, they're in a place where they want to be hugged, can do more than anything. And knowing just when to walk away. Go take a break, leave for 5-10 minutes. You come back and it can be a whole new conversation, can start over. And so often it's not what you say, it's how you say it. And then when I say incentive, I'm not above bribery. It's okay. If you do this, we'll get some ice cream, right? Whatever works. So deciding when changes are necessary. I'm really barreling through a lot of concepts because I really want to have a robust discussion. So I want to talk about tolerance for risk really quickly. Each person has a different tolerance for risk. So really think about, what is your tolerance for risk? Are you the person who drives in the fast lane on your way home? Or are you the patient person who's driving 2 miles under the speed limit in the right-hand lane? What is the consequence if something doesn't go as well as we hope it will? And is there disagreement about the tolerance for risk within the family? It's so often the case that some people have zero tolerance, say for the big one about tolerance for risk is driving. So some people have a lot of patience and a lot of tolerance for the risk of someone continuing to drive. And some people say, absolutely not. We have a diagnosis of dementia. We're going to take those keys away and we're going to make this change to not drive immediately. But usually people are somewhere in the middle. But it's a decision that is faced by most people at some point during the disease process. And so sort of being aware of your own tolerance for risk can be really, really important. Sometimes we're too tolerant. Sometimes we may need to pull back a little bit, right? Or sometimes we need to be more tolerant for risk, the dignity in risk. So considering the degree of risk in the situation, what are the risk factors? Is it acceptable risk? How long has it been like this? What's different now from the past? What are the potential consequences? And what is the likelihood of consequences occurring if a person refuses to accept help or refuses, say, to stop driving? What are we going to do then? So we want to be proactive, not reactive. Again, I'm repeating myself. I realize that. I'm going to keep going pretty quickly. We want to address internal and external triggers that you can identify: who, what, where, when. So physical health, communication, tasks, the environment. Identify strategies to decrease or eliminate the behaviors in the future. If, when the situation happens again, you'll be prepared. Okay. So now I'm just going to focus on you all before we get to our questions and answers. So I want to point out how different relationships affect your experience of caring for someone. So a spouse and an adult child experience this very differently. Or if you're a grandchild or a sibling or an ex-spouse, a friend, and sometimes it's a system of family and friends and not one or two particular people. So when there are disagreements between, say, the spouse of the diagnosed person and the adult children, we always want to talk about how their experiences of this are different. So other important factors that I think impact the experience of giving and receiving care: people who are sort of just natural caregivers and people who are not. I have had many conversations where I have had to say, after knowing somebody for a long time, I have to say, you're not cut out for caregiving. We have to find another solution here. It's a really hard conversation to have, but it's completely okay. It just means that it changes our plan. We just want to know the truth, right? Let's just put the truth out on the table. But there's so many different cultural norms, the implied level of responsibility. So maybe there's someone who isn't married, and so people think that person has all kinds of time on their hands. Or the adult daughter is sort of implied that the oldest daughter will be the person who needs to take responsibility. Obviously, differences of opinion, relationship history, personalities, promises. Family promises is a big one. So being really careful about what we promise, because we never know what this is going to be like throughout the course of the disease. So trying not to make promises. The caregiver's health and competing responsibilities. So what else are we dealing with? We're dealing with guilt. I think guilt is a big one. Redefined roles, social isolation, the 24/7 nature of caring for someone with this disease, financial stress and burden, and loss of reciprocal relationship. I think all of this can be captured under the word grief. Grief is the big one. Grief is what it's really about, I think. So we have two ways of thinking about grief. The first is anticipatory grief, looking to a point in the future when we are going to lose someone. I think with dementia, a better description of it is ambiguous loss. Someone we love is still physically with us, but cognitively, psychologically, they're slipping away from us. So we have a loss of a relationship with the loss of the relationship we used to have, but the person is still there. So, and the relationship changes, but the person is right in front of us and they look completely normal, right? So that's an ambiguous grief. And then a few words on guilt, a little bit more, usually stems from caring so much. We want the best for the person. We want the person to be safe, happy, involved, free of pain and worry, and our intentions are good. We are good. But there is always this nagging feeling of not quite being good enough. I don't know how many of you experience that. I experience that on a daily basis, and I strive to fight it all the time. No matter how good you do, it's that one thing that you wish you had done differently. If I had just done one more thing, if I had just, said something differently, everything would have been different. And that's just too hard. There's a helpful voice in our head that allows us to examine our fears and what's realistic and what's needed. That's a good voice. But most of what eats us up alive is the unhelpful voice of guilt, which really isn't productive at all. So if I had my druthers, if I were able to write prescriptions, I would give a prescription for the memory medicine for the person diagnosed, and I would give a prescription to the care partner to tend to your physical, emotional, and social and spiritual needs once a day. Not so easy, not so easy. So the ABCs are pretty simple. Aware, being attuned to what your needs and limits are and your resources. Know what helps you renew. Where are your renewal zones? What works for you? Is that working in the garage on a project? Is that doing the lawn? Is it doing a yoga class? Is it doing Ageless Grace? What is your renewal? What works for you? Practicing mindfulness and self-compassion, and acknowledging that we're all changed by this experience. We're all changed by this experience, and it's okay. So those are the A's, the awareness. Then we want to balance, is really a hard word to apply. Healthy food, movement, and sleep. Joyful activities, laugh, finding opportunities for art, music, playfulness. Maintaining your hobbies. Spirituality, whatever that means to you. And spending time in nature. And then staying connected. Connection to oneself, others, and something larger than ourselves, if that's something that resonates for you. Breaking the silence of unacknowledged pain. This can offset isolation and increase validation and hope, which means finding your team, finding a group of people who understand, or one other person who understands. Humor. We have to keep our sense of humor about things to get through this. And keeping your personal life and your relationships. Ask for help. Receive help. Allow help to come to you. So many people don't want to burden other people, but people really do want to help. And it can be a beautiful thing in a relationship to really accept that help. And keep in touch with those people who nourish you, like I said before. So the resources the Dementia Caregiver Support Program is a resource for all of you. We really want, at the beginning, if you remember what I said at the very beginning, that the first thing on this path is knowing what the diagnosis is and knowing what the future holds. The next thing is to ask for someone who's going to help you with I'll use a jargony word for social work, the psychosocial part of living with dementia. The day-to-day living with dementia is the role of the social worker on the team. That's the part that we can help with. So ask the doctor to be connected to the Dementia Caregiver Support Program. You can call us or email us directly, visit our website. That's probably the easiest thing to do. You can contact us through there, and you can also learn about all of our programs. If possible, meeting individually with a social worker. We are limited. We're a very small group. We're a new program, and we have 3 social workers. So if you are you or the person you're caring for are seen in neurology, geriatric psychiatry, geriatric medicine, or palliative care, we are able to meet individually. If you're not in one of those clinics, the Alzheimer's Association, 24/7, they're available, a 24/7 helpline. And we can put this in the chat if somebody would for me, because I remember the number after working there for a decade. The Alzheimer's Association 1-800 number, 1-800-272-3900. 24 hours a day, they're available. So the next thing, I think, after you sort of have a sense of what's going on and you've had the opportunity to meet with someone individually, continue with the workshops, find a support group, attend a health and resiliency class. It means carving out an hour, a half an hour, an hour and a half like you did this evening to come here and learn, to really build a community around yourself. Know that you're not alone. There are a lot of people who are here to help and a lot of people who really can understand what you're going through. So those are all my slides. So I'm going to stop sharing. I'm going to ask Barbara to help us with questions, and we'll go from here. You're muted, Barbara.
Early on, the first comment that came up was, and this is when you were talking about, logic doesn't prevail, don't argue when possible. This woman wrote, "This is the most difficult thing to do," 2 exclamation points. And you acknowledge that throughout the talk.
Not arguing.
Yeah. And a comment from Amy, someone in her support group has the motto, quote, "Do you want to be happy or do you want to be right when it comes to dealing with your person with dementia?" So I think, right?
Want to be happy or do you want to be right?
Right. And here's a first question for you, and it comes up in others. Do people with dementia have insight into their illness? Are they in denial? Do they have insight? How can we sort that out?
Such an excellent question, and thank you for bringing it up because I did not really address it. So it's very hard to know. There is a name for this condition that I can never remember the word. I don't know if you remember it, Barbara, but there is a word for lack of insight. Basically, your brain has to be working fully for you to have insight and awareness to what's happening to you. It's a very strange and very kind of hard to understand symptom, but it's very real. So really not being able to recognize what's happening to yourself. What can be more frustrating? The thing that's hard to know is it can happen very early to some people. Other people maintain insight for quite a while into the disease process, but at some point, it's something that is usually lost at some point. I will say that I don't, very rarely have I seen psychological denial. It's more about really being able to understand and respond in a way that's from insight.
Thank you. And to follow up on lack of insight, there are times when a relative refuses to go to a neurologist because there's nothing wrong with me. Could you comment on that?
Sure. I think that this is an example of, it's an example of a task you want to get done, and the person either doesn't see the need for it or may be fearful and doesn't want to go, right? But may really feel like they're okay and do not recognize the problems that they're having. I think that it's a combination of all the things that I talked about tonight. I think that you want to find, if you can, some reason that would make it okay for the person to see a doctor, and then leaving all the other details out. And the other thing that I didn't really talk about is chunking information. So taking small bits of information at a time. So it may be, today we have an appointment, let's go, right? You don't necessarily have to go into any detail about what the appointment is. We have an appointment at the doctor's office. Just kind of taking it one step at a time. Let's go out to the car. Let's put your coat on. Let's go out to the car. We're going to go to this appointment, et cetera, et cetera. So really chunking the information into small bits can really be helpful. I think that's a strategy for more advanced dementia, but it's an important one and certainly something that can be very useful. I think for someone in very early stage who really doesn't want to go see a neurologist, I think that being patient and being compassionate about it and starting with the PCP, seeing if the PCP can can help you accomplish the appointment? Is there someone in the person's life who they may respond to? I know recently someone got around this because after 6 months of trying to talk to her husband, their oldest daughter came to talk to her father, and he was willing to do anything for her. So sometimes it's a trusted person how frustrating is that? Said nothing different than what his wife had been saying all along, but it's just was something different with the relationship with his daughter. So that's my response to that.
And just somewhat of a follow-up.
Barbara, before we go further, I want to say one more thing. That's also an example of the perfect time to call the Dementia Care Collaborative support program, the Caregiver Support Program, or call the Alzheimer's Association. Sometimes bouncing the problem off of another person who gets it, somebody who has some expertise, can really be helpful. Don't feel like you have to problem solve by yourself. So if something doesn't go right, okay, that's to be expected. No reason to get mad at yourself or the person. Maybe this is something it would be helpful to talk to someone about. So that's just another really important point I wanted to make.
An important one, a comment somewhere along the lines, I'm also interested in the degree to which a person with dementia can consider their own condition. In our case, there isn't denial, but it seems difficult to self-examine in any way.
Yeah. And I think that's perfect wording. I wish I had stated that so eloquently, because I think that is what's missing in the brain, is the ability to self-examine, to be aware, and to really look at oneself. And I think that also speaks to empathy. I think sometimes empathy is lost. So the ability for the person to really put themselves in your shoes, put themselves in the shoes of the caregiver, can be very hard for them. And that loss of empathy with someone who you love and care about very much is very, very difficult thing to deal with.
And another helpful comment, an important question. Susan, are there ways to encourage a person to be positive and proactive in living with a disease, for example, like Greg O'Brien, versus being passive and not really thinking of themselves with the disease and just letting it roll on?
Well, not everybody is Greg O'Brien. Yeah. For those of you who don't know, Greg O'Brien is someone who wrote a book a couple of years ago now. He's been, and he still speaks. He does talks about living with Alzheimer's himself. And so there are those people who maintain insight and awareness, but I would say it's more the exception than the rule. It's more unusual for people to maintain that insight for a very long time. I think that the best way to get somebody to do the positive things that we want to do is to model for them, where we're making a plan for what's the plan going to be today, incorporating healthy activities, joyful activities, and sort of modeling for them and sort of helping them less words, but really kind of incorporating those things into daily life. Does that answer the question, Barbara?
Mm-hmm. I think that you spoke a lot about modeling, and that's so beautiful and so important.
Okay.
Susan, if my relative can't use language at a sort of later stage to describe maybe a pain, a belly pain or discomfort, what do I do?
Well, I think there's a lot of guesswork in this. I think that having them, again, instead of verbally describing, you're probably already doing this, but instead of trying to get them to verbally describe, ask if they can show you what hurts or where the pain is. Maybe touching on the belly a little bit. Is this what hurts? So gesturing, pointing to those kinds of nonverbal interactions. I think it's great to be aware that there is there possibly could be some pain that's contributing to maybe some change in behavior, irritability, that sort of thing. And to call the primary care doctor is a great way to kind of deal with that and get some help in figuring out what medically is going on. Sometimes you don't have to know exactly what it is, but if you're able to pick up on the fact that the person's having pain, that's really wonderful. I heard a statistic many years ago, and that in a memory care unit of a nursing home, Tylenol is used about 50% as much as it is used in the non-memory, the traditional side of the nursing home. Meaning it's not that they're having any less pain, but they're not able to ask for Tylenol. They're not able to express when they have pain. And so often it's missed.
A couple of questions about people around us. When is it time to tell friends and family about a spouse or children about the diagnosis?
I think this is such an individual family discussion. I think that, because, I don't want to impose my thoughts. I don't want to impose I think it's very much has to do with with the family's values and sort of what's most important to them. I don't see any reason for shame about this. I find that family members often know that something is going on, but they are afraid to ask because they don't want to, be intrusive. But that if they find out, or when they find out, there's actually so much compassion and love there, it can be a really good thing. And that is from family, from friends. But I think that I absolutely talk through that decision with every family, even how to do it. Some people will write a letter that'll go to many people so they don't have to repeat the story over and over, and they can express in that they need your patience and your compassion and your help. So there's a lot of different ways to go about it, but if someone is dealing with that, I would love for you to talk to someone again and really think through the options.
Our colleague, Amy, wants people to know that the Alzheimer's Association, though it says Alzheimer's, they're available to people with all forms of dementia. Right?
Thank you, Amy. That's a perfect point.
Yeah. Let's see. Some really other important questions. Oh, three people want to know, Susan, if the slides will be available to them after the program.
We can send slides out tomorrow.
Okay.
For sure. Yeah.
Okay.
I'm looking at Judy in my pictures here to see if she's given me a thumbs up. Good. We can send the slides out.
Here's a really good question. They're all really good. How do you help the dementia patient structure and find meaning in their day when they can no longer work?
That's a really big one. I think it is. I think we help. We can have an influence, if not, planning the day. We can have a lot of influence on what is planned. I think sometimes people can have a lack of motivation and a lack of initiative that is very real. Sort of the ability to start an activity is really impaired by the disease. But if you can get them sort of over that hump of getting over that hump of lack of motivation and initiative and get something started, they really can enjoy it. Some people are just very passive, so it makes it even harder. But I think what you plan throughout the day, remembering this person's interests and hobbies, or what they did for work, are there ways to incorporate that? My favorite example of this was a gentleman I worked with, their family for a long time, and he was a carpenter by trade, So he worked with saws and all kinds of dangerous equipment. His hobbies were hunting and riding motorcycles. And without those three things, he didn't know what to do with himself. And we were just stumped. What are we going to do? So actually what ended up happening was he had friends who he rode motorcycles with, and they included him for many, many years and would take him with them, and he would go with them. He wouldn't hunt, but they would be with him and include him in the day's events. So, but I think it is around providing, cueing, putting things in front of someone, taking someone to a place that they might enjoy, is really what it's about. And I can't help but wanting to ask Barbara Moskowitz for her input when I feel like I'm not adequately answering a question. So add in anything if you feel, Barbara, that would be helpful.
I think you're absolutely right. And one of the things you say all the time is this is all trial and error.
Right.
Even though you've helped us be prepared, we're talking about human behavior, which is always trial and error, and this too. So just exactly right. Thank you. By the way, Susan, we have two very smart people in our audience who problem is if I can pronounce it. Both Amy and someone else tell us, remember, the lack of self-awareness is ANOSOG, nausea. And Anna's, you get it? ANOSOGNOSIA. Judy, remember that. It's the lack of self-awareness.
Smart people out there.
Thank you, smart people. We appreciate that. Are the resources for getting home help and for guidance with meds, such as for moods and for seizures? Outpatient, this is one person with important comments. Third comment is, so resources for help at home, guidance with meds for moods and for seizures, and also outpatient guidance for difficult situation is not readily available. So, but is that when you'd say the Alzheimer's Association?
Well, I would say, depending on what physician is involved. So if you don't have a specialist involved, it may be time to get one involved. If a person has dementia and has a history of seizures or a new onset of seizures, and just thinking about how difficult it is to manage any medications that might affect mood and some of the psychiatric symptoms, that's a very specialized, that's like an art form as much as it is a science. So I would recommend finding a specialist for that if you haven't already, either geriatric psychiatry or a neurologist who works specifically with memory disorders, or even a geriatric medicine doctor is a great person to have on the team if you have access to that. We do have access here at MGH. So,
Susan, while you're talking about the resource of geriatric medicine, we have two questions about, someone is asking, how can one find a support group for caregivers? And then along as resource, someone else is asking, is the individual consultation available to a patient who's seen at the Brigham?
Okay. So I just want to go back and make sure I answered all of the questions that the first person had. So resources for home health is challenging right now.
That's right.
Just because of COVID and staff shortages and all of those things. But I think it's an excellent thing to call the Alzheimer's Association about. There are also care managers that are available, private care managers that can help with all kinds of care planning and accessing resources. They're pretty expensive to hire someone, but if there are resources, it is a worthy investment to get help with these things. The Elder Service Agency in your area has, every area has an Elder Service Agency, and if you don't know where that is or who that is, the Alzheimer's Association or we can help you with that. So there's a couple of places to go to find home health resources. Was there any other part of that question that I?
Yep, thank you.
Okay.
You answered all of those questions.
Okay, so support groups. Well, I'm speaking to the support group leader here. Barbara Moskowitz leads 3 support groups here at MGH, but they are also support groups in the community that the Alzheimer's Association supports and sponsors. So if for some reason one of our groups is not meeting at a time that's convenient for you, or if there's no openings right at the moment, our groups stay very close to being full. We haven't had to start a waiting list yet, but just in case you couldn't get into one of our support groups, the Alzheimer's Association is a great information place for another support group in the community.
And you could find out about that by calling the helpline, which you gave us, that 1-800 number. A really important comment. This is also helpful. Any advice for how to manage someone who is no longer safe to live alone, according to their medical providers, but who insists that they are fine to live independently?
That's the biggest challenge. Oh my goodness, where to even start? I think, my heart goes out to you if that's the situation you're in. I think that someone who has been so independent and always lived on their own or lived independently, to suggest that something is wrong that they don't understand, it's quite a pickle. It's really a difficult situation. So I think that's another one where problem solving with an expert would be really helpful for you. I think that, again, it's patience. It's really focusing on one thing at a time as much as you can, maybe a little bit here and a little bit there, to see if you can start inserting some supportive services. So there's a number of ways to approach it, but it does take some problem solving, and there are people who are out here to help you.
And somewhere in the same family, the question is, how do you respond to a person who has insight that something is very wrong, but doesn't know what it is?
I think that's true for most people who don't have insight, who have the word that they spelled for us that Barbara and I cannot pronounce. I'm just afraid to try it because I'm afraid I'll butcher it so badly.
Judy knows it. Yeah. Sorry.
Oh, that's okay. I think that people generally, even if they don't have insight into memory loss or the losses of function that they experience, people know something is wrong. Something isn't right. And I think that's what causes so much depression, sadness, frustration. Those things come from something's not right, So I think that what we really try to do is go back to habilitation that we talked about, providing a structured routine, positive emotions, looking at the environment. All of those things are how you start to put together a way to help that person who doesn't have insight but knows something is wrong. We want to provide them with positive activities, positive interactions, and ways to be involved and engaged in things.
Two important comments, one about a mother and one about my husband. My husband recognizes, we have about 7 minutes, Susan, and enough questions to take us to the end. My husband recognizes that he has difficulties with memory, but he thinks he will improve. How do I respond?
It's okay. I would say that's great. I hope it does improve. That's sort of the positive response. I don't think that it's something that we might know differently, or we might not anticipate it, but it's okay for that person to hope. and to really want to work on their memory. That's great. What we know will be helpful for your memory is what we're eating, is getting some exercise every day, really to help that. And actually, if mood improves and you get some exercise and lots of good blood circulation in the brain, things might feel better. Even if the memory doesn't improve, the person might really feel better. So I think it's a hopeful thing to say, and I would kind of go with it.
And how do you redirect and reassure when someone insists on handling financial matters he's not really capable of handling? For example, he calls American Express about late charges, but doesn't really explain why he's calling clearly enough for the person on the phone to help him. And he doesn't want me to take over.
I think finances are such a safety concern. It's a lot of damage can be done if people don't get some protection around their finances. So I think this is one of those situations where I would be looking for another trusted individual. Sometimes if there's, say, and I'm just guessing at this point, but I just want to, as an example, if in a marriage the one person is always taking care of the finances, it feels very difficult to allow the other person in. But another trusted person, maybe like an adult child or a good dear friend or financial advisor, might be able to at least start with helping to make a phone call or writing some checks to pay bills, doing it with him instead of doing it for him. And I think that's a good approach for anyone to take in that situation, is to do it together. And you may say, I've never done this before and I really need to learn for myself. Can you show me how you take care of these things? So that's sort of a positive approach to really address the emotions of the person.
That's great. Susan, one more. I know you're going to love this question. And then we'll end with a couple of suggestions others have. Here it is. Is it possible to get respite care to recharge batteries? How do I do it? Where do I do it?
Well, respite care is a word that covers a lot of different avenues to get it. So respite is getting a break. So respite may be for 4 hours. I would say no less than 4 hours to really benefit from respite. To really get benefit from a break, no less than 4 hours. Can I say that again? I really mean that. Less than 4 hours, you'd never really quite shift into what you're enjoying, and you're already thinking about, I got to get home, and you're worried, so at least 4 hours. But it comes in the form of anywhere from having a friend come over and have coffee with the person, and maybe lunch so that you can get out, to hiring someone to be there for part of the day, to, either if they need some help with personal care, that's when you get out of the house, right? That's a good time. There are adult day health programs. I don't know where we stand with those with COVID, but in theory, that's a great resource. But there are also options for, say, assisted living facilities where you can go and stay for a week, 2 weeks. I'm sure everyone differs a little bit on how long you stay. Some of them require a 2-week stay or a month stay, but that's sort of the other end of the respite spectrum.
And so we'll end on some great ideas. Ray said, this is in terms of activities, which was what he said, have an activity table, dominoes, Scrabble, tiles, pennies. And he says, not puzzles. And then someone else said, love that idea. We'll try it. And then there's another comment in terms of getting help. The agency Seniors Helping Seniors is a great resource. They offer companions to spend time with, go for a walk, play Scrabble, not activities of daily living. These are, she's saying, these are people who don't come in to give your relative a bath. They are absolutely companions. They also have monthly support group for caregivers.
Yeah, so Seniors Helping Seniors is a great way for you to get respite.
Okay, and very last, and then we'll end. The Woke Center, WOLK, for memory health is another resource. They offer an integrated approach to care for the person with dementia, a wonderful neurologist, nurse practitioner, counselor, and gerontologist. So lots of great ideas. And I guess, Susan, the time has come. There are many people expressing their gratitude for this helpful conversation. Judy, it's 6:58. So, Susan, on behalf of a whole lot of people who stayed for this wonderful, important night, I thank you. There are never enough times to hear this important information because it's so complicated, it's so hard to integrate, and to hear it as clearly as you described it tonight and as colorful as you did was so wonderful. Thank you.
Thank you, Barbara, and thank you for being my colleague in this effort here at the Dementia Caregiver Support Program. We love building a community with you all, so thank you for coming. We hope you'll come back next month. Barbara, what's the program next month?
That's right. Next month on February 15th, you will have the pleasure of hearing Beth Solsberg. She directs the Alzheimer's support program at the Jewish and Family and Children's Service. And if you've heard of memory cafes, she's also the leader of that. So thank you, everybody. And thank you, Susan. Judy.
Thank you, everyone, for your attention.
And thank you, Susan. You're all going to get an evaluation. It's a really quick one. And if you can just fill it out, it usually comes by tomorrow morning. Fill it out right online and just send it back in. That's really helpful to us to know what kind of programs you want.